Welcome to the Australian Dental Council Explainer podcast. Welcome to the debate. This content is for educational purposes only and does not constitute clinical or professional advice. Imagine you're a clinician, the patient is in the chair, they're anesthetized, ready to go. You pop open the lab box, pull out this pristine metal framework, and well, your stomach just completely drops.
Oh, the worst feeling.
Right? Because the indirect retention you thought you prescribed is just entirely missing. But wait, it gets better. The lab technician has sort of gone rogue and added a reciprocal arm that you didn't even ask for.
Yeah, a classic curveball. Welcome to Case 30, everyone.
Exactly. Today we're speaking directly to, dentists, dental prosthetists, oral health therapists, hygienists, and of course students preparing for exams. We're looking at a scenario that really tests both your clinical mechanics and your ethical baseline.
For sure. And the core question we are debating today is, whose fault is this?
And I am taking the position that the fault inherently lies with the clinician. The clinician is, at the end of the day, the ultimate architect of the treatment plan. They are the final gatekeeper of patient safety, and they bear the absolute legal and ethical duty of candor to the patient. You can't outsource your liability to the lab.
Well, I am coming at it from a very different perspective. I'd argue that the fault here is a systemic product of poor team dynamics and really hierarchy-related conflicts. This case perfectly illustrates a shared breakdown in communication between the clinic and the laboratory. It's not just some solitary, isolated clinical failure. I mean, if your lab feels like they have to quietly fix your work, you don't just have a mechanical problem, you have a systemic one.
I hear that, but I think we need to start by grounding this in the reality of clinical liability. Like, for those listening who are prepping for their clinical exams, understanding the ultimate locus of responsibility isn't just an academic exercise.
No, it's definitely not.
Right. It's your license. When you're the treating practitioner, you're the one putting your hands in the patient's mouth, and you're the one actually signing the lab card. Duty of candor isn't just some, buzzword. It's a legal tripwire.
Okay, but
Let me just finish this thought. It means the moment you realize the lab omitted a component, you lose the right to quietly adjust it and send the patient home. You have to sit them up, look them in the eye, and admit the prosthesis is flawed, period. If a framework returns without indirect retention, you either failed to design the lab card correctly or you failed to enforce the standard when it came back. You own the error entirely.
that is a very strong legal baseline. I'll give you that. But I'm just not buying that it explains the actual anatomy of this specific error.
How so?
Have you considered framing this through the lens of modern patient safety research? Specifically, if you look at James Reason's Swiss cheese model of medical errors?
Oh, right, the slices of cheese lining up?
Exactly. Healthcare errors are rarely just one person making one isolated mistake. They're a series of systemic failures, like the holes in those slices of Swiss cheese aligning perfectly. Your argument really only looks at the very first slice, which is the clinician's prescription.
Well, it's the most important slice.
But we have to look at the fact that the lab technician in this case made an autonomous clinical decision to include a reciprocal arm. That completely proves the error isn't just a simple one-way dictation failure. It's a complex, two-way communication breakdown within the oral healthcare team. If we just point the finger at the clinician and say, "Your fault," we are totally ignoring the sick communication system that allowed the error to happen in the first place.
Hold on. Compensating for a mistake is one thing, but practicing dentistry without a license is another.
Oh, come on, they aren't practicing dentistry.
Well, they're making design changes, right? And the technician doesn't know the periodontal status of that abutment tooth. But let's actually unpack the biomechanics of this error, because it's not just a missing line on a piece of paper. We have a framework missing in direct retention.
Which is a big deal, yes.
A huge deal. Functionally, we need to visualize the fulcrum line. So imagine a line drawn between the two most posterior rests on the abutment teeth. If the patient has a distal extension, a free end saddle, that saddle acts as a class 1 or class 2 lever.
Right.
When they chew something sticky, the food grabs the acrylic and lifts it away from the tissue. The saddle rotates around that fulcrum line, lifting the front of the prosthesis. We place indirect retention far away on the opposite side of that fulcrum line to physically block that upward rotation. So missing this is a massive biomechanical oversight.
Exactly. It's a huge oversight, which is actually why the lab's intervention is so fascinating here. Let's talk about what that added reciprocal arm actually does mechanically.
Okay, let's hear it.
When you have a retentive clasp arm engaging an undercut, it has to flex over the bulbous part of the tooth every single time the patient inserts or removes the denture. That flexing puts a really strong lateral force on the abutment tooth.
Right, which is why we reciprocate.
Precisely. Think of the retentive arm like someone pushing hard against a heavy door. If there's no one on the other side of the door pushing back, which would be the reciprocal arm, the door just swings open. In the mouth, if you don't have reciprocation, that lateral force acts like an orthodontic appliance.
Yeah, over time, it torques the tooth right out of its socket.
Exactly. The reciprocal arm ensures the clasp is guided, reciprocated, and fully engaged without traumatizing the tooth. The fact that the technician remembered this proves they're actively trying to save the clinician from their own poor design.
I see why you think that lab intervention is some kind of saving grace, but it absolutely doesn't absolve the clinician. I like to think of it this way, treating the laboratory technician like an autonomous architect, rather than a collaborative builder, leads to these exact discrepancies.
I'm not sure I agree with that analogy.
Just think about it. If the builder adds a load-bearing pillar because they think the architect forgot it, but they still forget to build the roof, the architect can't just shrug when it rains. The dentist signs the blueprint, which means they absorb the liability. Does the lab assuming some rogue design liability actually excuse the clinician's initial failure to draw the indirect retention?
I really have to push back hard on that architect-builder analogy. A dental technician is not just a bricklayer following a blueprint.
I'm not saying they are just bricklayers, but
They are highly trained professionals with deep, specialized knowledge of dental materials and biomechanics. Often, they understand the mechanical limitations of a framework way better than, say, a new graduate dentist does. The real question here is, why didn't the technician pick up the phone?
exactly my point. Why didn't they call?
Well,
Because they shouldn't be making clinical guesses in isolation.
no, they didn't call because of the rigid hierarchy in dentistry. Maybe that technician has been chewed out by a dentist before for daring to question a clinical design. Time pressure, fear of the clinician's ego, and just rigid power dynamics often dictate that the lab should just do what they are told.
You think they were afraid to call?
Or in this case, quietly fix what they can without confronting the architect. When the clinic and the lab aren't functioning cohesively, you get exactly this, a Frankenstein framework where one error is missed and another is autonomously corrected. The root cause is the team dynamic, not just the solitary clinician's inability to draw a receipt.
That's a really interesting psychological angle, I'll admit, though I would frame the hierarchy quite differently.
Of course you would.
Well, the hierarchy exists for a reason, and that reason is clinical reality. The technician does not know the patient's medical history. They don't know the specific occlusal forces in function or if an abutment tooth has compromised bone support. Therefore, autonomous design decisions are just inherently dangerous.
They can be, sure.
But let's move from the abstract to the practical, because our listeners need to know how to actually manage this clinically. The guidelines give us two specific mechanical choices here.
Yep, option 1 and option 2.
Right. Option 1 is to accept the framework as is, ignoring the missing indirect retention on the basis that there is good direct retention with the 3 clasps and the added reciprocal arm. If it fits, you basically take a chance. Option 2 is to take a pickup impression, cast a separate rest and minor connector, and try to laser weld it onto the existing framework. So how do you justify proceeding with a compromised framework under option 1?
I strongly advocate for the pragmatic approach, which is option 1. And the clinical guidelines provide a very clear, evidence-based rationale for this.
Even though it's missing a key component?
Yes, because you have excellent direct retention. There are 3 clasps, and crucially, you have that reciprocal arm locking the system in. Because the technician intervened, the mechanics of the direct retention are highly stable. If the framework fits beautifully in the patient's mouth right now, taking a calculated chance and proceeding is a completely clinically valid option.
A calculated chance?
We have to weigh the reality of the mechanical situation sitting in the chair against an ideal textbook scenario that frankly doesn't exist anymore.
I'm just not convinced by that, because it fundamentally challenges the ethics of our practice. I mean, can a clinician really just look at a prosthesis, recognize a missing element that actively prevents rotational displacement, and choose to run an uncontrolled experiment in the patient's mouth?
It's not an uncontrolled experiment.
We prescribe indirect retention to protect the abutment teeth from damaging torque. If you just take a chance, you're gambling with the patient's periodontal health. This is exactly why option 2 exists.
Option 2 is a nightmare.
You correct the error. You fabricate the missing rest and connector, and you laser weld it to provide the patient with the prosthesis that was actually required without completely remaking the entire metal base from scratch.
Okay, that sounds great in a perfectly sterile, theoretical world, but have you considered the actual metallurgical realities of option 2? You can't just glue cobalt chromium together.
Well, obviously.
These are incredibly stiff, highly rigid base metals with extremely high melting temperatures. When you attempt to laser weld a new piece onto an already cast framework, you have to hit it with immense, localized thermal energy.
Yes, laser welding is a highly specialized skill, but it is routinely done in high-end laboratories.
It's done, but at what cost to the fit? When you blast that alloy with a laser, the rapid heating and subsequent rapid cooling create what's called a heat-affected zone. The crystal lattice of the alloy fundamentally changes. It introduces massive residual stresses into the metal. The framework physically distorts.
Not always.
Often enough. So you take a framework that fits the patient's dentition perfectly today, you send it away to be blasted with a laser, and it comes back warped. Now the clasps don't engage correctly, the major connector rocks. The clinical guidelines explicitly warn against this because the failure rate is exceptionally high. The cost implication is significant, and the final fit is usually totally unsatisfactory.
I mean, it is a risk.
You are taking a perfectly fitting, albeit slightly compromised framework, and destroying its most important feature, its adaptation to the tissues. Option 1 isn't taking a wild gamble. It's making a calculated clinical judgment that a well-fitting, stable framework is safer than a warped, welded one.
Okay, I will concede that the metallurgical realities of laser welding chromium-cobalt alloys make option 2 fraught with technical difficulties, potential distortion, and unpredictable costs. I'll give you that. However, if we accept your premise and choose option 1, proceeding without the indirect retention, we immediately collide back into the duty of candor.
Right.
And this is where the rubber meets the road clinically.
Go on.
The duty of candor mandates that the patient must be explicitly informed when their treatment deviates from the accepted or planned standard. If you choose to proceed with option 1, you cannot just quietly fit the framework, adjust the occlusion, smile, and send the patient home.
Oh, absolutely not.
Right, that is a breach of ethics and law. You must sit the patient up, explain that the prosthesis is lacking a planned component, explain the specific biomechanical risks of that omission, like potential rotational lift during function, and obtain their fully informed consent to proceed with the trial fitting. In doing so, the clinician must absorb the fault in the eyes of the patient.
I agree with the transparency part.
The patient doesn't know the lab technician, nor do they care. They care about the clinician they're trusting and paying.
I completely agree that the patient must be informed. Transparency is entirely non-negotiable. But I really want to stress that resolving this case ethically doesn't stop when the patient leaves the chair.
What do you mean?
If we just have the clinician fall on their sword, apologize to the patient, and absorb all the blame, we do absolutely nothing to prevent this exact same error from happening to the next patient tomorrow.
But the clinician absorbing the liability is how the system is designed to work. It forces them to be more careful next time.
But it doesn't fix the root cause. Resolving the root cause requires addressing the conflict resolution within the oral healthcare team. We're trained to look for root causes in disease, right?
Sure.
If a patient presents with rampant, recurrent caries, we don't just keep drilling and filling the teeth. We look at their diet, their saliva, their systemic health. When a clinical error occurs, the disease is the communication breakdown. True candor means breaking down that professional hierarchy.
Okay, but
It means the clinician needs to pick up the phone, call that lab technician, and have an open, completely non-punitive conversation. You need to say, hey, thank you so much for catching the missing reciprocal arm. That really helped. But we need to talk about why the indirect retention was missed, and more importantly, why you didn't feel comfortable calling me before you cast the metal. Candor is an internal team requirement just as much as it is a patient-facing requirement.
that is a highly idealized view of clinical practice. It sounds great on a podcast, but it totally overlooks the harsh legal framework of healthcare.
Does it though?
Yes, the legal liability doesn't care about your internal team dynamics or your non-punitive conversations. When a patient signs a consent form, they are entering a binding contract with the practitioner, not the laboratory.
Legally, yes.
If that framework ultimately fails in 3 years because the lack of indirect retention caused excessive torque and subsequent periodontal failure of a key abutment tooth, the regulatory body isn't going to investigate the lab technician's feelings about hierarchy. They are going to look at the clinician's notes.
Well,
The duty of candor in action means taking absolute ownership. It means documenting framework returned, lacking indirect retention, patient informed of risks, patient consented to trial option 1. If the clinician tries to diffuse that responsibility onto the team, they are failing their fundamental, legally mandated duty as a healthcare provider.
it's not about diffusing legal responsibility. It's about accurately diagnosing the pathology of the error to improve patient safety long term. By acknowledging that the lab technician made a clinically impactful, autonomous decision to add that reciprocal arm, we are acknowledging that the lab is already operating as an active part of the clinical team.
Active, maybe, but we have to treat them as such rather than as passive vendors. If we ignore the systemic factors, we are just treating the symptoms of a broken system, and the errors will just continue to slip through the cracks of the Swiss cheese.
Let's bring this back to the core takeaway for the practitioners and students listening. We are analyzing a very tangible scenario here. Case 30. A framework arrives with a dangerous design flaw compensated by an unprescribed yet helpful addition.
The clinician is faced with a biomechanical dilemma and a strict ethical imperative. To summarize my position, the clinician's ultimate authority over the patient's care means they must shoulder the fault entirely. The clinician is the architect. Whether the builder fails to follow the plan or the blueprint was flawed to begin with, the clinician must execute the duty of candor, own the error directly to the patient, and make the difficult choice.
Right.
Whether that choice is taking a calculated mechanical risk with option 1 or accepting the cost, distortion risks, and complexity of a laser-welded repair under option 2. At the end of the day, the buck stops with the treating practitioner.
And to summarize my perspective, healthcare errors in the modern era are rarely solitary events, and treating them as such is really counterproductive. They are systemic failures of communication and hierarchy. The ultimate takeaway here is that a rogue addition from a lab isn't just a mechanical variable. It's a diagnostic symptom of a sick communication system.
Fair point.
If your lab is fixing your work quietly, your hierarchy is too rigid. While the clinician obviously manages the patient relationship and the legal consent, the fault for the error occurring is shared. Resolving this case fully requires team-based communication and addressing the systemic barriers that prevent a lab technician from calling a dentist to clarify a prescription. Without fixing the team dynamic, you are destined to repeat the error.
It seems we have found a critical point of convergence here. We both agree that regardless of whether one views the fault as an isolated clinical failure or a systemic breakdown, and, whichever clinical path is chosen, whether it's proceeding with the 3-clasp framework and thanking the lab, or attempting a complex metallurgical revision, the ethical obligation to the patient remains paramount.
Definitely.
The duty of candor just cannot be bypassed or minimized.
Absolutely. The patient's right to know the true status of their prosthesis is the one non-negotiable element in this entire scenario. There's certainly a lot more to explore in this material regarding team dynamics and patient safety protocols, but the patient's informed consent must always come first.
We will leave it to the listener to decide who is ultimately at fault for Case 30. Think back to that initial moment of opening the lab box. The prosthesis you hold in your hand isn't just a piece of cast cobalt chromium. It is the physical manifestation of your clinical judgment, your team's communication protocols, and your ethical standards. When it doesn't match the textbook, how you proceed defines the exact kind of practitioner you are. For more dental examination preparation tips and clinical deep dives, subscribe to our Spotify and YouTube channels and share this episode.